Hi, I'm Monty Mythen, Editor-in-Chief of Top Med Talk. Welcome to Fluid Matters. It's a special mini-series looking at all aspects of perioperative fluid and hemodynamic management. So this is another excerpt from Controversies in Perioperative Medicine organised by Duke University Medical Center in the USA. Recorded in June 2018, this is specifically from the Great American Fluid Debate. The question posed was goal-directed fluid therapy versus goal-directed hemodynamic therapy. Dr. Tim Miller from Duke University Medical Center tees up the debate. I'm in the chair, and the panel includes Dr. Stuart Grant and Paul Wischmeyer from Duke University Medical Center, along with Professor Mike Grocott from Southampton University in the UK. It's a great conversation, and it ends up talking about enhanced recovery after cardiothoracic surgery, and interesting discussions about lessons to be learned from excessive hemofiltration during on-bypass cardiothoracic surgery, and perhaps that overzealous hemofiltration, there are some lessons to be learned comparative to those that we've learned from fluid restriction in non-cardiac surgical patients. Top Med Talk. Tim Miller, you've met already, Professor of Anesthesiology, Chief Division of General Vascular and Transplant Anaesthesia, Duke University Medical Center, President-elect, American Society of Enhanced Recovery, father.
And I do declare I am also a goal-directed therapy enthusiast. Okay. So we've heard about the difficulties in doing restrictive and liberal, the confusion of those terms, the difficulty in knowing where you are. And obviously there is another, particularly in enhanced recovery, most of the enhanced recovery literature will include a goal-directed therapy component. So this is just going to be a brief presentation, and then we can debate both goal-directed fluid therapy and perhaps goal-directed hemodynamic therapy as well. Same disclosures. So this is going back around 10 years now. Daniel Chappell published this article, A Rational Approach to Fluid Therapy, and the whole title implicates that he thought we were doing fluids irrationally, which I think I'm going to argue is the case. This is the way we do fluid management at Duke, to try and get our patients in that sweet spot, typically 1 to 2 kilos heavier. So we divide fluids into maintenance therapy and volume therapy. Our maintenance therapy, we use lactated ringers. We put it on a pump at 3 mils per kilo per hour based on ideal body weight, which is around 200 mils for most patients an hour. Obviously, we use ClearFast as our carbohydrate drink. I have no relationship with the company. We allow NPO till 2 hours beforehand. We give them the ClearFast, and then, so we don't think they're significantly hypovolemic when they arrive, and we do a maintenance therapy. So typical 4 or 5 hour major abdominal surgery, they'll get about 1 litre, just over, of their maintenance therapy. And then in addition to that, we do goal-directed fluid therapy, i.e. we used an advanced cardiac output monitor to measure stroke volume, and we give boluses of fluid, a combination of either colloid, albumin or crystalloid, to optimize patient on their Starling curve to try and individualize their fluid therapy. So why do we do goal-directed therapy? The physiology behind this goes back to 1928, this quote: "It is a source of regret that the measurement of flow, stroke volume, is so much more difficult than the measurement of pressure. This has led to an undue interest in the blood pressure manometer. Most organs, however, require flow rather than pressure." And I always liked speaking about this when Monty's here, because when Monty was a resident, he was very keen to get some publications, and him and his friends decided to put arterial lines and 14-gauge catheters into each other and bleed out 25% of their blood volume. Probably wouldn't be able to get IRB approval to do that now, but if you do that, if anyone wants to have that done to them later, please let me know. If you do that, you'll find that your body will maintain blood pressure, because it's designed to do that in response to hemorrhage. It will try aggressively to maintain blood pressure, to maintain perfusion of your brain and your heart at the expense of blood flow to your gut. So when they also put nasogastric tubes down each other, and just to compound the misery, and measured gut perfusion, that decreases significantly, and your flow or your stroke volume decreases significantly as well. And this has been repeated in recent healthy observation studies at Duke, again bleeding out 25% of blood volume in our human pharmacology and physiology lab. The problem with flow is that for a long period of time we were unable to measure flow with any devices other than putting a Swan-Ganz catheter in, which obviously we're not going to be able to do. But over the last 15, 20 years, as we've had minimally invasive cardiac output monitors, we can measure flow. So we can measure stroke volume, so we can use fluid challenges to optimize patients at the top of their Starling curve. So if on the left there, patients on the steep part of their Starling curve, they're hypovolemic, the blood pressure may still be normal, hasn't yet dropped, but they've lost some blood in the bucket, we give them a fluid challenge that'll increase their stroke volume by greater than 10%. When they get to the top of their Starling curve, they'll no longer increase their stroke volume by 10% with that fluid challenge. And that's the basis for individualizing fluid management with goal-directed fluid therapy. So we think of a typical case as it goes along. Your patient may be a little bit dehydrated when they arrive. So you give them a fluid challenge, the stroke volume goes up, significantly more than 10%, maybe 15, 20%. You give them another fluid challenge, and then you hold just with your maintenance crystalloids, 3 mils per kilo per hour based on ideal body weight, until there's a little bit of a change. Sometime during the surgery, stroke volume drops more than 10% below your trigger, you'll give more fluid there. The idea to try and individualize it so we keep the patient on top of their Starling curve whilst keeping that maintenance low and not giving them fluid excess. So we look at example protocols of this. This is a typical protocol: stroke volume optimization, monitor stroke volume, give fluid challenges with colloid, and then look for 10% changes in stroke volume. Another protocol which is very similar but also includes stroke volume variation, that dynamic variable to try and predict fluid responsiveness. So you measure stroke volume variation. If your stroke volume variation is high, you've got that little bit of swing in the arterial line, then you'd give them fluid and that till it goes less than 10%. And then you continue going round this algorithm. So there's been a number of studies that this goal-directed fluid approach have reduced complications. This was a meta-analysis published in 2011. I think Mike Grocott was on this. I wrote the accompanying editorial suggesting that we should use this goal-directed fluid therapy approach in all major surgery. However, a lot of these studies were before the enhanced recovery era. None of those studies were really done within enhanced recovery. Enhanced recovery itself helps fluid management. A typical patient with a traditional pathway would get very hypovolemic initially and then get a lot of fluid, as I've described. So they have 2 times where they enter into this red zone, first early on when they're very hypovolemic with bowel prep and with starvation, and then later on if they get that 5, 6, 7 litres of fluid towards the end of surgery. It was fairly easy within this blue line as your control to show a benefit with goal-directed fluid therapy. If within your enhanced recovery pathway you're trying to give them the carbohydrate drink, avoiding prolonged starvation, just doing a sort of sensible fluid management, if that is the case, you may be not staying more in this green zone without using advanced monitors, particularly in lower risk patients. And we're starting to see this within enhanced recovery with goal-directed therapy studies. This is one published last year in ANA that didn't show any benefit, and now we're talking about laparoscopic surgery. So again, perhaps fluid management is arguably somewhat simpler to a certain degree within laparoscopic surgery. No benefit, and they said previous benefits of goal-directed fluid therapy may have been offset by subsequent improvements in perioperative and surgical care. Let's switch a bit away from fluids to just thinking about blood pressure as well, because I think this is an important component of it, and we'll move on towards another approach, which is perhaps goal-directed hemodynamic therapy. So another thing that we've really become prominent and over the last year or so is hypotension, and does hypotension matter? And some of this is from large database work from the Cleveland Clinic, from Daniel Sessler and his group. And this culminated in perhaps the most provocative paper yet of perioperative hypotension, which is by Futier and colleagues, which was published in JAMA. And again, it's great that we can talk in this meeting. We've already mentioned about 4 or 5 manuscripts that have been published in either the New England Journal or JAMA on fluid and hemodynamics. And we could not have said this even 3 years ago. And I think it's great that we're getting these studies into big journals. So this is a very interesting study. It's fairly small, and this needs repeating. 300 patients. But what they did, they compared standard of care, and standard of care was, just to let you know, was let your systolic go down to 80 and then give ephedrine. That was what they did in their standard of care group. But they compared that to an individualized blood pressure group where you use dilute peripheral norepinephrine infusion. Let's say that again, dilute peripheral norepinephrine infusion to maintain blood pressure within 10% of baseline. And as you can see, they showed a significant improvement, reduction in postoperative organ dysfunction with the group that had blood pressure within 10% of baseline. The important caveat that is hard to see in the manuscript is that both groups got goal-directed fluid therapy, and particularly in the norepinephrine group, they gave at least 2 fluid boluses before they squeezed. So the unintentional consequence of this paper, if you just read it at face value, could you start using norepinephrine or phenylephrine infusions to maintain blood pressure in hypovolemic patients? That is not what they did here. They optimized volume first and then squeezed, and we'll come back to this. So this, you could argue, is more of a goal-directed hemodynamic therapy. This is another paper just specifically looking at goal-directed hemodynamic therapy. Whereas what they did, they looked at fluid status. If the pulse pressure variation was high, they gave fluids. They did that first. If the cardiac index happened to be low, they gave inotropes. If the blood pressure was less than 65, they gave vasopressors. And finally, the last study, which has just been published this year, Monty's one of the authors, so I'm sure can talk about it. Again, goal-directed hemodynamic therapy, multi-center. Very nice algorithm, I think. They measured stroke volume as well as blood pressure, so using a cardiac output monitor. They gave fluid challenges using the 10% rule to optimize stroke volume to get a patient who is nice and full circulation. Then, if the patient was still hypotensive, they started a vasopressor at that point. And there were only 3 or 4% of patients who had a low cardiac index. That's really higher risk patients. They weren't afraid in those patients to start an inotrope. This is goal-directed hemodynamic therapy. They showed a reduction in length of stay and a reduction in complications in the goal-directed hemodynamic therapy group, particularly AKI, pulmonary edema, ARDS, wound infections. So all complications that you think can be related to fluid management, either giving too much or too little. So this is our POCI guidelines on fluids. We said we recommend the application of a hemodynamic framework to guide decision making. We suggested goal-directed therapy is likely to be safe and has little risk. The only risk is it costs a few dollars, but there's no evidence in any of the literature it causes harm. And this was our algorithm, and this is what I recommend at Duke. You look to see whether there's a clinical problem. You use this, which is your brain. And then if you think the patient's hypovolemic, you give fluids. If you think they're vasodilated, you give vasoconstrictors. And if you think they have decreased contractility, you use inotropes. And then you go back and reassess. That's me.
If we could reassemble our panel. Tim, fantastic. Tim, where are you at Duke with regards to the use of vasopressors? Because this has become a very hot topic. And certainly where I work back in the United Kingdom, it's perceived that you can't, if you want to give a norepinephrine infusion, you have to go to critical care or a similar environment. Whereas we've been in a number of audiences in the USA where people say, no, we can give it peripherally. And in that Futier paper, as you say, it was crystal clear that in the appendix it says 2.5 milligrams and 250 mils given via a dedicated peripheral IV line. Where are you on that?
So we do not use norepinephrine infusions outside of the sepsis world. So a lot of our patients, we will optimize fluid first, and then typically we use a phenylephrine infusion if the patient's still hypotensive. We use a fair number of epidurals within our enhanced recovery, so there are a number of patients that will be hypotensive even if their fluid's optimized, and then we will use a low-dose phenylephrine infusion. What I don't want to see is the infusion going up and up and up and up and up, but if they use a little bit of background phenylephrine infusion, I think makes sense. Physiologically, it probably makes more sense to use norepinephrine infusion, and we've discussed this. It gives a little bit of beta as well, and probably physiologically makes sense, but that is going to be some change there if we start using norepinephrine infusions in the OR, or bringing patients back to PACU on norepinephrine infusions, because people associate, even if you're handing over to one, they're attending or a CNA, they're on a little bit of norepinephrine, you'll be like, what? Are they going to sick you? I mean, you associate that with being sick. So if we're going to use norepinephrine, that is going to be a sea change. If we're going to start using it peripherally, that will be a sea change. If we're going to start having a second concentration of norepinephrine, this dilute concentration, I know pharmacy is going to have a lot of objections to that because of confusion with having two different strengths. UVA in Virginia, were using peripheral norepinephrine, and they actually stopped because, again, they had pharmacy issues. We did a survey. Anyone here using peripheral norepinephrine for non-septic patients?
There we go.
One. We did a survey, I can't remember, recently when we were talking about this, and there were more hands. There were about 10% of the audience, but still it's not many. The majority of people are using phenylephrine.
So that suggests, along with the fact that published in JAMA, in the appendix, having assured that it's an... We're not suggesting you should do this, but the idea that you have to go to ITU and it has to go through a central line is another one of those made-up things, as far as we can see. It may be
and there is literature supporting that. You probably don't want to put it in the 22 gauge at the back of the hand, but...
Because the fear is extravasation, isn't it? That's the fear. It's not that there's something magical about it going into a great vein, because we get, on the ride over here yesterday a couple of times, my norepinephrine levels in my vessels was probably higher than you would give me to make my blood pressure go up just a little bit. So that's not the issue, is it? Anyway, we're spending a lot of time on this, but I think we're going to be revisiting how and where we use the vasoactive agents, because the recurring theme in these positive trials that aren't just fluid balance is for the major patients, which are often sicker and older. It's about a quarter of the patients or so are getting vasoactive agents to make the difference. And we're not going to be sending all of those to ICU to get that benefit, are we? Some other comments? Where do you stand on this, Stuart?
I think the use of vasoactive agents goes along with the use your brain bit. I have some frail and elderly patients, and if the BIS can be 15 and people got the phenylephrine running, it's amazing. You should avoid the recipe, yes, and engage brain. Really make sure the anaesthetic is appropriate for that patient, because sometimes I think these are used as the band-aid that people put over, covering other problems, and it's how we filter this out into our own practice, one paper, another institution, and Norepi. I'd like to slow down, because you shouldn't jump there.
Yeah, you shouldn't use it to fix what you caused, didn't you? Because I think in here somewhere it even includes things that you should look to see if you're giving them too much anaesthetic, which is a common cause of a low blood pressure, and or how you've used your regional technique as well. Mike?
It is striking when you look at the hemodynamic, the goal-directed hemodynamic therapy studies, where in one arm you've got an infusion and in the other arm you don't. A surprising number of patients are getting boluses. So taking as an example the optimised study, I think about 85% of the patients in the control group who weren't getting infusion of, in that case, dopexamine, they were getting bolus pressors or other hemodynamic type drugs, and that must be less stable. So if you give any credence to the kind of Dan Sessler, even a minute below 65 carries with it risk, if you're bolusing rather than infusing, you're more likely to be in that area.
So just to repackage that, in these large prospective randomised controlled trials, when you look at the control group and they're writing down every vasoactive drug that was given, more often than not we're bolusing vasoactives, which something in our head is telling us we're not doing it because we're doing it with a stick and we're giving little pushes of it, but we're doing possibly the same thing but in a less effective and controlled way.
Potentially.
Paul, comment on that?
Yeah. I think two thoughts. One is on what Stuart said. In the ICU, or at least in the surgical ICU, I would never fathom letting the residents use phenylephrine. I mean, we'd only use norepinephrine. The data for norepinephrine improving outcome is, and largely in sepsis, mind you, but in shock in general, is so overwhelmingly better than any other vasopressor. There's nothing else we'd hang, but I have to tell you, we're treating our own over-sedation not infrequently. I still see way too much propofol go up in the ICU. It's not meant to be an ICU drug. And we cause a lot of depression ourselves. It requires Levophed. It's amazing. I'll walk in the morning, turn the propofol off, put a little Precedex and opiate, usually it's lack of opiate, on, and the Levophed goes away.
And do you use the norepinephrine peripherally? It's funny because I know the MICU has done that for a long time, and they've always been mocked for it.
The MICU at Duke.
The MICU at Duke.
Yes,
norepinephrine infusions with no central line, no A line, anything.
So it must be all right then.
And we've always mocked them, and then maybe they were.
What did you mock them for?
Well, I would say, coming from a peds background too, I saw a lot of extravagation of multiple drugs.
Okay,
I would say there's Levophed and phenylephrine. Neither has got any data that one is safer than the other that I've ever seen. Any vasoconstrictor that escapes into the skin, including calcium, can end up bleeding to a skin graft. So I don't know that either is one. If you're going to give something peripherally, you're going to give something peripherally, and I don't think Levophed is of greater risk than Neo than any data I've ever seen.
So these are not things we're advocating, but just keeping an eye on them.
If you have to make the choice, and Levophed the better drug, I've never seen data say that giving that peripherally is higher risk than giving Neo peripherally.
So one of the developments we're seeing, I get the impression, is the greater use of longer peripheral lines, so that they end up closer to the great vessels, and then you can quickly confirm it's in the right place with some ultrasound. That seems all pretty sensible to me. I'm not advocating any products here. These are all in emergence, but that sounds pretty sensible to me. Put in a longer peripheral line and make sure it's in the right place with an ultrasound. It's easy. We're
not using those much.
I think it's all coming. So please identify yourselves if you want to join in on this. We'll come back to our friend who was suggesting that we don't have the right technologies, which I'm sure we recognise there are deficiencies in it, but please do indicate if you want to come in on this whole discussion. I'll get to you in a second there, sir.
Question at the front, Monty.
I'll get to you in a second there. Ma'am, can we just come back, and I'll come to you, ma'am, in a second, because you were up beforehand. Can I just come back to your comment, which I thought was, we jumped on the saline thing, which I know you were basically saying that's an isotonic crystalloid, and we use saline as slang when often we mean Hartmann's or Plasmolite. But with regards to the deficiencies in the monitoring opportunities, can you bring us back to that one?
Sure, Mary Ellen Lapis, Cleveland, Ohio. We try. We try our best. We want to do goal-directed therapy all the time, but you go to different procedures and really nobody has a consensus. No one will agree that one is the gold standard, that really one monitor tells us where we are in the patient. And then we treat the patient, and it's kind of like up in the air where we are at the end of the case in terms of being that 1 to 2 kilo up, just 1 to 2 kilograms up. So I just wanted to get your take on what do you use for different surgeries, or is there a gold standard monitor that you can use?
No, there is no gold standard monitor, and I think that there are a variety of different monitors out there. I think the most important thing is the technique and not the monitor. And I think the second most important thing is when you're talking about the accuracy of the monitor, there is some variation between the monitors. It's how you use the monitor. And I think rather than looking at an absolute number, if you would look at percentage changes, so you're looking at fluid responsiveness, I think that is the best way of trying to get the patient at the right place.
So Tim, to deal with the broad categories, our basic monitoring allows us to do a lot already, doesn't it? There's a lot of information that we can use. We can use end-tidal CO2 changes, we can use subtle variations in blood pressure, we can use the plethysmographic trace on our pulse oximeter. So there's a rich data set there already. And for the cardiac output monitor specifically, there are 3 broad categories. There are those that you look at something, modified echo type of signal, like descending aortic velocimetry. There's those that feed off an arterial waveform of some form. and there's those that use a bioreactance or bioimpedance methodology. Now, I think in your institution you use or have used all three in different ways. So there are horses for courses, as far as we can see.
And there's finger cuff ones, which we use as
a derived arterial waveform, a finger plethysmographic that derives an arterial waveform. But big, broad categories. But it's how you interact with those that makes the difference. Stuart, I know you want to come in on this.
So just what something Tim was saying, I mean, in the death throes of the pulmonary artery catheter, people would say, well, I know the data says it doesn't make a difference, but in my hands it does. Do you think we're seeing more of that as we sort of get tighter, we're avoiding the extremes of too little fluid or too much fluid, that it probably won't make a difference? Do we need them at all?
Is anybody in the room prepared to put their hand up and say that they're a less than average car driver? Okay, it's very, very honest. If that's true, I suspect if you're that reflective, you may not be. But
I know we've got two colleagues who are prepared to admit that, and they don't drive cars anymore. But they're special people.
But if we look at the data, the chaotic fluid data, and we all look at that and we think it's somebody else, but that kind of can't be true. We're all in that data. And one of the great advantages of the monitors is that they at least put some constraints around how much fluid is administered and induce more thought about how it's administered, as opposed to, I'm in trouble, I'm going to open the tap, there's another litre gone. And simply in that respect, I think they have advantage.
So if we stand back and look at the epidemiology, every time I've looked at it in large data sets, different size data sets, different institutions over decades, about 1 in 10 of us is a good guesser. Reliable, good guesser. About half of us are okay most of the time. Half of us are not doing a good enough job, and 1 in 10 of us is frankly dangerous. So that's an interesting, and that's reinforced by those publications time and time again. Paul, some comments on that, and I'll get our next question.
Yeah, again, coming from the ICU perspective, the biggest change I've seen is the ability for everybody that comes out of training now to be able to wield an ultrasound probe. And so, when they actually get sick enough to come to us, I rarely give large amounts of fluid without having the resident or fellow. I mean, literally my residents are doing this now. Put the ultrasound probe on the chest and tell me what the IVC looks like and what the heart looks like. I don't think I can't fathom practicing critical care or high-level acute care perioperative anesthesia without that. I can't believe we practiced before we could do this.
Okay, I'm going to hand over. I think it's Mary now who's going to ask us a question.
Mary Brandon from Richmond, Virginia. Just with all of this, I've been thinking about, I spent a lot of time in the cardiac OR. Is anyone, or you all, or is there any data out there looking at enhanced recovery, goal-directed fluid therapy, or goal-directed hemodynamic therapy, and immunonutrition with the cardiac surgical patients? Because I feel like fluid therapy in that room means fluid restriction as much as you can. And most of those patients, I feel like, also come to us malnourished.
Two great questions.
The answer is not as much as they should. And there's a bit of a movement now for ERACs, is it? Enhanced recovery after cardiac surgery. And
cardiothoracic surgery, there's a T in there.
Cardiothoracic, sorry. And we're starting to do this a little bit of Duke. I mean, I don't do cardiac myself. Other people in the room may be able to comment more. I think it gets more confusing with obviously going on bypass. And I know Mike Manning and others at Duke have looked at we're starting to filter large amounts of fluid off pump during bypass to maintain a hematocrit, and these patients are coming off pump pretty dry and then being squeezed, and there's no particular algorithm in how that's done. So patients are often 3-4 litres of fluid are filtered off, come off pretty dry, squeezed, acute kidney injury rates of 40 to 50%. So I think there is some room for improvement, but
So the early, and Mike may could comment on this, the early goal-directed fluid therapy was dominated by cardiothoracic studies.
Well, you've done studies in it yourself.
Exactly, and some of the biggest ones done with the Swan-Ganz catheter or done with were and why wouldn't that be a great place to do it? And somehow that's drifted away to having less confidence in the use of monitoring at all, and this obsession with desiccating people at the end of bypass. Now, what a fantastic environment where you're smothered in monitoring and all the drugs are available and everything to just get it right. Mike, comment on the literature?
I mean, there are relatively few recent studies, but I mean, you're absolutely right. The early studies were very rich in cardiac studies, and the signal was very similar to that which was seen elsewhere. And in a highly monitored environment where they're going to a highly monitored post-operative environment, it seems like a very easy win.
Today in a cardiac, let me just introduce myself. My name is Renata. I'm from Stony Brook. I just want to ask you right now, with hearts, actually with cardiac, we moving towards minimally invasive cardiac with TAVRs and mitral clips and things like that. A lot of these patients come from home and even like nursing homes, very malnourished. Is there any, I should say, benefit of also doing immunodirected nutrition therapy in the minimally invasive cardiac patients? Those are like the particularly frail and elderly ones.
You know, to get to both your questions about that, there is a fair number of studies of immunonutrition in cardiac surgery. In fact, probably the highest impact factor journal that's published in is in Lancet. There was a cardiac surgery trial that actually looked at immune function as well and found it to be better. So there is data, and you could see I presented some of it in the meta-analysis that we did, and that number has grown. So we do think there's benefit. We do think the greater the surgical insult, the greater the benefit of immunonutrition would be. So I think probably the frailty of the patient combined with the size of the surgical insult is the key combination. So I don't know any data in TAVR yet. I think we just don't have data there yet. But I think in the larger cardiac surgeries, we definitely do, and they would definitely benefit.
Sharon McCartney from Duke. I'm one of the cardiac anesthesiologists and intensivist. To go back to Dr. Brandon's question, what are we doing in enhanced recovery in cardiac surgery? This is a hot topic at the most recent national SCA meeting, so I think there's going to be a lot more coming out in the next couple of years. And to reiterate what Dr. Miller was saying, we found that at least at our institution and probably at institutions worldwide, because I'm sure we're not very unique, people were ultrafiltrating at the end of bypass, or actually throughout all of bypass, and we'd look over and there was 3-4 liters easily in the canister, and the perfusionists were very proud. This was almost like a trophy, how much you could ultrafiltrate during bypass. And conversely, once the patient gets to the ICU, in the first couple postoperative days, there was high incidence of AKI. Obviously, 30% rate in all comers in cardiac surgery, but we were seeing much higher rates. So we now have instituted that at every timeout, when the surgeon says what cannulas he wants to use, he also says what the ultrafiltration goal will be for that patient. Because amongst the surgeon and the anesthesiologist, we know the patient the best. And even if it's a heart failure patient coming in for a heart transplant, they've likely been in the unit being aggressively diuresed and are not necessarily hypervolemic when they come for their heart transplant. And so we know this historical information much better than the perfusionist, and so we make this a conversation at every case.
I find that the cultural context fascinating, that the same wording around the sort of the trophy volume of fluid that's taken off with ultrafiltration is exactly the same kind of feel as we're getting in the restrictive group in non-cardiac surgery. And for whatever reason, for a period of time, that's been cool. And I don't know why not giving the right amount isn't cool.
So, and a little bit personally disappointed because the research I did, I think it's probably 30 years ago now, was in the face of that being fashionable at the time. In other words, desiccation was somehow thought to present post-pump acute lung injury. And we demonstrated in a small study that was the start of that journey that optimizing left ventricular end diastolic volume throughout the case, i.e. keeping the patient euvolemic, produced much better outcomes. We seem to be back there again. Somehow desiccation, all made up, somehow saves lives. Where'd that come from? I don't know. True, unrelated. Last question or comment?
Marwan Obeid, King Hussein Cancer Center from Jordan. Sometimes it can be confusing, for example, how much fluid we should give, because some surgery, for example, if I am doing laparoscopic Whipple, for example, last 7 hours, or liver hepatic resection, or open surgery that lasts 10 hours, it's a good idea to think that we should not give too much fluid. So this is called restrictive. So why not to call it optimized fluid therapy, rather giving restrictive fluid therapy? So for example, giving the optimal amount of fluid to have, for example, using Vigil or whatever cardiac monitoring, with and give the maximum stroke volume, for example, having the variability less than 10, and then if the blood pressure is not, or stroke volume is not good enough, then to use inotropes. So why not to say give the optimal rather than restrictive fluid therapy, because this will confuse people most of the time.
Yeah, I completely agree. And Monty interviewed Paul Miles on the Top Med Talk after the relief study, and Paul was very, very clear that this didn't mean going back to liberal fluids. This meant just a little shift from where we were to try and get in that optimal zone. And the classic U-shaped curve of fluid management is to try and get in that optimal zone. And so whatever we do for the terminology, we're not saying super liberal, we're not saying super restrictive, just get it right.
As you said, sir, individualised, goal-directed hemodynamic management, of which the first step is getting the volume right. In closing, does anyone disagree with that? That's a loaded question, because we're just about to have a break. Right, I'll say thank you very much indeed to our wonderful panel, and thank you to you for participating in this discussion. Top Med Talk. So some great takeaway messages there. If you want to cross-reference any of that to other articles on Top Med Talk, please go into our podcast section on topmedtalk.com. Go into our search engine, and whether it's hypotension or goal-directed or restrictive, put those terms in and you'll get access to a whole host of other podcasts. If you want to come and meet the Top Med Talk team, we're going to be at the EBPOM London meeting coming up shortly. That's EBPOM, E-B-P-O-N. So go to their website, ebpom.com, and come and meet the team.